open the door for all the biologics that we have today. So when we look at psoriasis, it's common amongst a lot of people. It affects, in the United States, about 7 million individuals. But it doesn't look the same in all people. So we want to remember that. Why do some people in your clinical practice only get guttate psoriasis? Why do some of them always get erythrodermic? And others may have your classic phenotype of psoriasis vulgaris. So think about that, because maybe some of those gene defects that we're picking up in psoriasis patients may be the key as to why certain people always develop certain phenotypic diseases. And so we need to investigate that, and that's not known today. We do know it's characterized by a hyperproliferative state. It's very itchy. It can have other components to it, pain, discomfort. It may have arthritis or swelling and warmth over the joints associated with it. And it can be associated with a number of other comorbidities. And we're seeing that monthly if you read the journals, that there's more and more evidence suggesting that psoriasis may be part of metabolic syndrome, or at least in some fashion associated with it. So we know that there's a number of things that can make psoriasis worse. We all hear that from patients. They're under stress. They might have obesity. They might smoke. So there's external factors that can trigger psoriasis, make it worse as well. We know that there's intrinsic factors. We know that patients who have cardiovascular disease may be at increased risk of psoriasis. But we really don't know what causes psoriasis. We know a lot of things that go wrong in psoriasis, but we're still delving down deeper and deeper to get to the actual, is there one little magic bullet that's defective in psoriasis? And we don't know that yet. We do know it's inflammatory, it's immune mediated, it affects joints as well as skin, but maybe it can affect other organs as well. Phenotypically, it can be varied. It can have inverse pattern. It can have classic vulgaris type. It can be near erythrodermic. It affects all ages of individuals, from kids to geriatrics. It can be guttate. So it has a whole varied presentation. And so why is that? Yet it's still the same disease in all these individuals, but they all look different. So again, there must be something that we're not quite getting. As I said, it affects the joints. It can affect classically the ankle and the small joints, like here where you see enthesitis. It can affect the axial spine and give people ankylosing spondylitis type pattern, and it can do dactylitis as well. So again, the same players are at play here, particularly the inflammatory cytokines like TNF. We see those same TNF players in rheumatoid arthritis, but why does rheumatoid arthritis present differently than psoriasis? So it's telling us there's not one thing that makes psoriasis or psoriatic arthritis its own entity. It's got to be a compilation of things. And so it may be simple, it may not. We don't know. We know the common denominator with all of this is that patients have very painful, fissured, cracked skin. They have terrible joints. They can get mutilating joint disease, and that affects their daily function. And it also affects, therefore, how you're productive in the workforce, how you are productive in your personal life. So it can impinge on people's everyday life, much greater, I think, than some other diseases. Now, regardless of the phenotypic presentation, we know classically and histologically this is what we see in psoriasis, right? We see acanthosis, expansion of the epidermis, that's going to equate to thick skin. We see an increase in angiogenesis, so it's going to be red, it's going to be inflamed, it's going to be painful. We see neutrophils collecting in the epidermis. If we measure keratin in the epidermis, we see expansion of keratin 16 pretty much in all the psoriatic plaques. So the histologic picture is similar. Phenotypically, it's different. So how do we get there? In order to understand it, I think we have to go back to basic immunology and think about our innate immune response. So on this side, you have your innate immune system. You have T cells, you have B cells, which we didn't put in here. You have plasma dendritic cells. So they're all sitting around waiting to do their job. And then you may have some trigger, whether it's environment, whether it's genetics, whether it's infection, it could be anything that's going to stimulate these guys to start proliferating and produce their cytokines. So a vast majority of them will go through proliferation and end up releasing a number of inflammatory cytokines. Depending on their trigger, they may develop Th1 cells, which then produce interferon and TNF. They may upregulate the Th17 cells and produce IL-17. The end result of those inflammatory cytokines is your psoriatic plaque. But part of the immune response also involves non-cytokine components, and that's what we call here, these are these co-stimulatory signals that must be activated in order to get to the end result. So we have some of these regulatory cytokines upregulating proteins such as the STAT proteins, which ultimately increase NF-kappa B, increase nitric oxide, and get the immune response going from a different arm. But the end result still means the epidermis or the keratinocyte is upregulated and shows acanthosis and all the other things that we see histologically. So it's a concerted effort between the whole immune response to get inflammation going. In 1995, I had just finished residency, had come on faculty with Dr. Milliken, and had been on faculty, and the state-of-the-art pathogenesis in 1995 was this schematic. Somehow or another, like a miracle, there were these T cells which lived in the skin. We didn't know how they got there, but that one little T cell caused all the keratinocytes in the area to start producing too much keratin 16. And somehow or another, they talked to those cells, and there were these inflammatory markers, a few of which they knew but didn't know what they did. But somehow or another, these cytokines were in the epidermis and caused the keratinocytes to make their plaque. So we thought everything is epidermis, nothing really going on in the dermis, although we forgot about what Dr. Buechner and other people in the 70s were saying. Well, why are those cells there? Why are there lymphocytes circulating in the blood? Why are the neutrophils in the epidermis? So people started looking at that, and we found out, as of 2009, that there's a whole plethora of T cells, primarily, that do get into the epidermis, but they start maybe up here, we don't know, and somehow or another get activated, drop down into the dermis, proliferate in the lymphoid tissue, and then are sent back to the epidermis where they release all of their inflammatory cytokines. So you can imagine this is just one arm of the immune response, but you can see numbers of chemokines, cytokines that are at play in order to make your psoriatic plaque. So it's not a simple one little cell releases a cytokine. It's this interplay of a whole lot of different cytokines that all have to work in sync to get your defect in the skin. So we're seeing expansion of our knowledge, and this is good because it's going to expand what we're able to treat our patients with ultimately. So in 2003, at least in the United States, there were two drugs that targeted specific components of the T cell activation pathway, and they were eculizumab or Raptiva and Alefacept, which was Amaviv. And these two drugs were like the thing that opened the floodgates for looking at ways to target the immune system. This drug very nicely bound to the LFA1 molecule, which is on a naive T cell. By binding to LFA1, the whole activation cascade was stopped in its track because this cell, which normally would bind to the antigen-presenting cell and start the whole activation pathway, was now unable to do it, so it halted in its track. So the whole pathway of activation was stopped. Now that's important because this is no activation occurs, right? Which you don't want in the real world. You want your immune system to work, especially when people have infections. So not real good. Alefacept similarly did a similar type thing, but it blocked at the CD2. Again, halting activation of the entire T cell cascade and your entire immune response. Not good, and they were withdrawn from the market. One, because eculizumab had some issues with long-term suppression of the immune response, and Aleficef, I'm guessing, didn't have much of the market. But anyway, so they were taken out. But it set the stage for looking at other pathway areas that you could block. So maybe it's not good to block the entire activation process. So shortly thereafter, there were a number of other agents that came out that blocked different parts of the pathway. And that was the whole run on a number of the anti-TNFs, which came out very quickly in the sequence, where they blocked not the T cell activation, but they blocked the product that the T cells made. So that's a bit better for a patient. Why? Because if they do have an infection, you're going to have some cells that are, your activated T cells are going to still be there, and you'd be able to mount some sort of a response. You just wouldn't have as much of the end product, TNF, for the most part. And then in 2013, ustekinumab came out as a first in its class, blocking a different component, but again, blocking not as far up as here, but farther up than the anti-TNFs. And we'll see that, we'll see that, let me get this back. When we look at now what we know in 2015. So we know, and there's still a black box over in this direction. We don't know what really activates these dendritic cells, but there's a number of dendritic cells that are naive. There's a number of components of the innate immune system waiting to do their thing. Those are neutrophils, macrophages, monocytes. So they're all around. And they're going to release inflammatory cytokines somehow to set the whole cascade in motion. So we don't know if this is genetic, if that's a trigger. But we get activation of our T cell, of our dendritic cell, and then that dendritic cell can go in two ways. If you have a lot of IL-12, you will shift the production of Th1 cells and thus more TNF-alpha, interferon gamma. In the presence of IL-23, you're going to shift those naive activated dendritic cells towards the production of Th17 cells. And so there's a number of players that are co-stimulatory molecules which help contribute to the production of either Th17 or Th1 cells, both of which are needed for the inflammatory response. And then those in turn produce effector cytokines, which then affect the keratinocyte and then go on to cause proliferation. And it also goes on to set up this chronic inflammatory loop. But what we found out when we saw that these Th17 cells were producing IL-17A, IL-17F, or the combination IL-17AF, was that those Th17 cells were more important than the Th1 cells in maintaining your psoriasis and your inflammation without the immunosuppression. These guys, if you block here, you get a little bit more immunosuppression, but it turns out these Th17 cells were more the pivotal cell that's really kind of getting more to what's going on in your psoriasis pathogenesis. So where we think we are today is around this spot, but we do know that other things produce cytokines outside this regulatory loop, and especially produce IL-17, and that's why people tend to get less infections with the IL-17 than with the other biologics, and that's at least what we propose at this point. But we have plenty of different targets that we still potentially can use to shut off the inflammation cascade and hopefully benefit patients with psoriasis. So we know, but we really don't know what is the exact starting thing or why patients get psoriasis. We know genotype is involved. We know that environmental factors can affect it. We don't know if genotype is the whole trigger. What we do know is that we have activated dendritic cells, we have activated mast cells, we have production of inflammatory cytokines, both Th1, mediated, which is TNF alpha. We have IL-17A. We have more IL-23 and not IL-12 being the key players for your psoriatic plaque and the whole chronic inflammation. So we know places that we can target and maybe very selectively target, and that's what you're going to be seeing over the next couple of years. But we don't want to forget this part of the pathway, because without that, you can still block the whole inflammation cascade. So we have our cytokines that are being developed, or monoclonal antibodies to them, and we have small molecular weight molecules that can impinge here, block interferon, and thus decrease inflammation from that arm and decrease psoriasis clinically. And those small molecular weight agents this is the first one to come out, and of course that's apremilast or Otezla. It blocks phosphodiesterase 4, which is key in activation of interferon. So by blocking PDE4, we see a decrease in inflammation. We see a decrease in nitric oxide production, a decrease in activation of interferon, and shutting down, or at least blunting, the cascade, because it doesn't do it as effectively as some of the monoclonal antibodies. So currently it's approved for psoriasis as well as psoriatic arthritis. And we also have other agents that are about ready to come out. So we can block PDE4 and prevent interferon, but we can block production of STAT1 by blocking the JAK kinase. And there's a number of JAK kinases which are involved in activation of the interferon gamma receptor. So if you activate normally, you would activate by phosphorylation, dephosphorylation, and then you upregulate STAT1, STAT3. Those go to the nucleus, and they activate the nucleus to produce inflammatory cytokines, particularly interferon gamma, which starts the whole activation process. So about ready to be approved, but not quite yet. We have two JAK kinases. There's one topical and there's one that's a pill that's going to be coming out for psoriatic arthritis. There is one that's already out for rheumatoid arthritis. So if we block JAK kinase, you induce or you inhibit gene expression of these inflammatory cytokines. And we have tofacitinib, which is already approved for rheumatoid arthritis, and it's the data has been submitted to our FDA for approval in psoriatic arthritis. So we have a couple of new agents that are going to be coming out, and there is a topical tofacitinib that you can also get that will be coming out in the United States, but it's not yet approved. So what do we have today? We have a number of different places within the pathway that you can block and effectively shut off psoriasis. We have our traditional methods like methotrexate, cyclosporin, which really just block the proliferation of your lymphocytes, period. So that's kind of generic, knocks them all down, not super selective, but some people it's what you can use and it's very effective. We have acitretin and methotrexate that will block, so you block keratinocyte proliferation, you block T-cell proliferation, and you should decrease your psoriatic plaques, and you do. We have ustekinumab, which blocks the P40 subunit on IL-12 and IL-23, and that can shut the process off upstream from that. We have agents that block TNF, which is the downstream result of activation of the immune arm. And all of these result in decreases in psoriasis. We have a new in class IL-17A receptor blockade drug that was just approved in the United States, secukinumab, which will block Th17 only. So you see we're getting more and more specific. We start real generic, then you get a little bit more specific, then you get further up the line, and then you get real specific so that you block just Th17. So that would imply, and we are seeing this, that you'll have less negative side effects by impinging on the immune system. There's a whole bunch of different anti-TNFs. They work a little bit differently, but as a class, they all block TNF. They do it by different mechanisms. There's several that are monoclonal antibodies, and there's etanercept, which is a receptor protein. All of them, with the exception of golimumab, were pretty much made from standard techniques, and golimumab is a transgenic antibody, which means it's a totally human antibody, but it's made in a rat or a guinea pig or somebody else, but not us. And all these other ones are actually the human gene that's put into non-human vectors. So, as I said, they all bind TNF. They have a little bit different efficacy, a little bit different action. Etanercept's the only one that blocks both TNF alpha and beta. The others are monoclonal antibodies, and they all have different efficacies, but in the individual person, they can be quite effective. And so as a group, we see that they're going to block anywhere that TNF is made. So it can come from any number. You can have keratinocyte-derived TNF. You can have macrophage-derived TNF. You can have your activated T cells. They all get blocked in some fashion. So we see that, and so we have a whole host of ones that we can use. So in my practice, I use them all. They're all effective when they work, and when they don't, you use something else. But you can see quite nice results with patients on the anti-TNF inhibitors. So now we go moving up the line, and we get a little bit more specific in our target, and we're blocking IL-12, IL-23, right? Because ustekinumab blocks the P40 subunit. So it's going to knock out both of these arms. So again, a little bit less specific than we want to see, but at least it's good, it's better, and it allows some of the T cells to still be activated. So we can block there, and how does it work? It binds the P40 subunit, which is shared by IL-12 and IL-23. So by blocking that, you don't get activation of the receptor, you can't bind. But each of those molecules, even though they have a shared P40, they have different effects in the normal immune response. So in the normal immune response, IL-12 is more geared up for infections, for pathogens, for bacteria, and they tell the immune system to do a little bit different things than the IL-23. The IL-23 is more important for memory T cells. So remember, in the beginning of the talk, I said IL-23, or Th17 cells rather, are the ones that are used for maintenance of your psoriasis. So if IL-23 keeps these memory T cells going, that's going to keep your psoriasis going. Or maybe that's where the defect for psoriasis is, we don't know. But what will happen if we block IL-23 preferentially over IL-12, right, then we're going to block this arm only, not this arm. So when you get an infection, you want this arm to work really well, right? When you want tumor surveillance, you want this arm to work really well. Here, this is just maintaining your psoriasis, or so we think today. And it might change tomorrow, but at this point, we're thinking this is even more selective. So if we can develop a target to block specifically IL-23 and not IL-12, we'll be better off. And sure enough, we've got phase 2 trials doing exactly that. So when we look at blocking IL-23 only, then we're going to knock out those Th17 cells. And we have several that are in phase 2 trials, and this is about this. Some of the data has already been submitted to the FDA, the guselkumab, and that actually shows very, very good PASIs. They have PASI hundreds that are in the 70-80%. Efficacy is good. Morbidities are down. So we have 2 new drugs that are coming out that are targeting just IL-23 to knock down the Th17 arm. They're in phase 2 studies and phase 3 now, looking at their effects in psoriasis. And they'll be coming out probably within the next year or so. Now we have a brand new in its class blockade IL-17A called secukinumab. I can't say those, but anyway, you get it. Ixekizumab is going to be coming out probably at the end of this year, early next year, and it also is an IL-17A blocker. Brodalumab was in clinical trials and phase 3, and Amgen just decided to not do any more work with that, and hopefully some other company will pick it up, because we're in that study and it's phenomenal results, but they are not going to pursue it. But neither here nor there. We have blockades of IL-17A, and we have a new one out, secukinumab. And so you're going to block the IL-17 effect only. And the new one that we have in class is secukinumab, or Cosentyx, and it does block IL-17A. Brodalumab had blocked the IL-17. Anyway, so it's given as an injection, and we have very good results clinically with that. Brodalumab, as I said, is going to be kind of X'd out. Will be coming probably towards the end of this year or early next year. So where we are at state-of-the-art pathogenesis in 2015 is not too far off from where we were in 2009, with the exception of the fact that we're getting more and more specific. And so there's also clinical trials looking at IL-22, because it turns out IL-22, which may be produced in part by Th17, or there is a subset that totally produces it, only affects the keratinocyte. So this would be a way that you could target IL-22, get rid of the skin disease, and only affect in the skin. And investigators are looking at that today. And what we do know as a group, so this is the good thing that we tell our patients, is if we look at all the agents we have today, regardless of the biologic, and sorry for that little typo, if we give a patient any of the existing biologics today, we see total reversal of the psoriatic plaque, you see decrease in expression of keratin 16, normalization of the skin. If Dr. Van Voorhees did a nice study where they looked at systemic inflammation, and so they did MRIs of patients who had psoriasis, and they looked at just whether or not they were treated. These are untreated patients, actually. And you'll see hot spots of inflammation. You'll see it in the liver. You'll see it along the aorta. You can even see it in some of the blood vessels, and you see it in the skin. So there's systemic inflammation going on. So psoriasis is probably not just a skin disease. I like to refer to it as a systemic skin disease. You give that same patient a biologic, all that inflammation goes away. So if systemic inflammation is contributing not only to the pathogenesis of psoriasis, but possibly to some of the comorbidities we see in it, then I think that one of the next phases we're going to be looking at is, does the biologic that we use to clear the skin help with systemic inflammation? And we don't know that. Intuitively, we would think it would, but we don't have that data yet. So what do the biologics do? They basically target the inflammatory cytokines that contribute to inflammation, contribute to clinical disease, contribute to joint damage, and overall decrease the inflammation. So we have a ton of medicines that we can use. How do you pick which one to use? Well, in our country, I think first and foremost, insurance is the issue, because these drugs are ridiculously expensive. So you have to make sure that patients can get them. Prior therapies help. What do people respond to in the past? They might respond to again. We don't need to look at classes and say that they must have an anti-TNF or an anti-IL-12, but it does help, because we know that in joint disease, TNF is a bigger player than IL-12/23, so intuitively the anti-TNFs may be better for joint disease than non-TNF mediators. But we don't know that. So all of those things come into play. So again, we look at what they've used. What we need, though, in the future is if there was some sort of assay that we could take a patient that looks like this and see what his genome is expressing, or see what cytokines are elevated, not unlike you measuring, your IL-6. So if we could see in that individual patient what is the predominant cytokine that's driving psoriasis, then you could have a better tool to pick which drug would be your better agent. And we don't have these assays yet. But that, I think, is something that we really need, is how do we tell which patient will benefit best, and that will make it the most cost effective, because you don't have to go through trial and error. The other thing we would like to find is there a particular marker that can identify a person who would respond to one drug versus the other? Does phenotype really correlate with genotype? We don't know that, but maybe looking at gene arrays might help us in determining that. We know we've come a long way. In the old days, we had tar. Today, we still have tar. We've had a number of toxic agents that we used for psoriasis. We had a lot of cytotoxic agents that we used, so systemic agents that kill everything, including the psoriasis plaque. Then we got a little bit more sophisticated and started targeting the individual cytokines, and so there's potential ways to target those cytokines. And these are the 4 potential ways, and we've done most of them. We first started with targeting the T-cell activation itself. That wasn't a good result in the end because it shuts off the whole immune response. So then we started looking at, well, the activated T-cell produces cytokines. We can target those. Not as bad, but not really super selective. So then we could go get more super selective and look at the individual cytokines that are being produced and block those. Or today we're trying to looking at what is their counter-offensive therapy. So how can we prevent it from happening? And so I think what we're looking at for the future is we want to really still home in on the pathogenesis because it's not solidified yet. We need new research that will allow us to pick treatments based on evidence instead of trial or error, which will save money for the system. We want to target those genes in maybe that individual that's causing the problems. And so we need to focus on treatments, I think, that are going to be tailored to the individual patient with psoriasis, not to the class of disease itself. And I think with that, I will end. Thank you.
Any questions? Yes.
Yeah, I enjoyed your talk.